We have already started at the NIH and with many of our collaborators on the developing of a vaccine. Right now that's being prepared. I anticipate with some cautious optimism that we will be in a phase 1 trial within the next 3 months. Going into a phase 1 trial does not mean that you have a vaccine that's ready for deployment. It will take 3 months to get into the trial, 3 months to get safety and immunogenicity data, and then you move into phase 2. What we do from that point on will be determined by what has happened with the outbreak over those months. Remember, we made a phase 1 trial with SARS, and we never had to use a vaccine. But nonetheless, we are proceeding as if we will have to deploy a vaccine. In other words, we're looking at the worst scenario, that this becomes a bigger outbreak.
One of the things that can be done, it's certainly not the total solution to the problem, is to delay, if not cancel, anything that's elective. I mean, any medical or surgical procedures that need to be done on an elective basis should not be done in anticipation of the fact that beds and equipment that you would use even in an elective situation should be used for people who really need it. Even though you don't see that now in certain locations, pretty soon there's going to be a stress on everyone's system.
Health officials, myself included, have said in the past that travel restrictions are not going to stop completely when you have an outbreak. That is a true pandemic. But I think most health officials agree that at best it delays, and as the Secretary says, kind of pauses things. And that's really the reason and the underlying rationale why that was done. I mean, if there is, and I hope it doesn't happen, a broad pandemic throughout the world, travel restrictions are not going to help. You can't just travel restrict everyone. But I think many public health officials would agree that although it's not perfect that it will stop, it could delay. And what we needed was a delay to essentially prepare better, but also to get a better feel of where this is going.
We are reasonably well prepared. We've had a pandemic preparedness plan that we put together years ago. And what the CDC was talking about is taking the process from containment to mitigation. And mitigation means to be prepared to do things that would slow down the spread if we had an influx of infections, such as closing schools, social distancing, teleworking, and things like that. We need to start thinking about that now, even though it isn't absolutely necessary to implement it now. The impact on the rest of the world is still a work in progress. We've seen over the last couple of weeks that other countries like Japan, Korea, Italy, Iran are starting to have community-based transmissions where you have sustained transmission from person to person. That becomes a big threat for the rest of the world, because if in fact it evolves into a pandemic, then every country, including the United States, is going to get impacted.
We're dealing with clearly an emerging infectious disease that has now reached outbreak proportions and likely pandemic proportions. If you look at, by multiple definitions of what a pandemic is, the fact is this is multiple sustained transmissions of a highly infectious agent in multiple regions of the globe.
The fatality rate is, of course, controversial because WHO just announced that they think it's 3.4%. You've been, I think, quoted in New England Journal of Medicine a few days ago. Said, well, it's probably less than 1%.
No.
Is that, where do you think it's going to end up? Because we don't know the denominator.
But
right?
You said it, sir. If you look at the cases that have come to the attention of the medical authorities in China, and you just do the math is about 2%. If you look at certain age groups, certain risk groups, the fatality is much higher. But as a group, it's going to depend completely on what the factor of asymptomatic cases are. So if you have asymptomatic cases that are a lot, it's going to come down. What we're hearing right now on a recent call from the WHO this morning is that there aren't as many asymptomatic cases as we think, which made them elevate, I think, what their mortality is. You know, as well as anybody, that the mortality for seasonal flu is 0.1%. So even if it goes down to 1%, it's still 10 times more fatal. system is not really geared to what we need right now, what you are asking for. That is a failing.
And a failing, yes.
It is a failing.
Very
Let's
much so.
admit it. The fact is, the way the system was set up is that the public health component that Dr. Redfield was talking about was a system where you put it out there in the public and a physician asks for it and you get it. The
Okay.
idea of anybody getting it easily, the way people in other countries are doing it, we're not set up for that. Do I think we should be? Yes, but we're not.
Early on, we weren't in the situation where we could actually get the tests out in a broad way. And I mentioned on the show last week that we need to get the private sector involved. And just a couple of days ago, we had the CEOs there who are going to be now putting it on full overdrive. So I would expect that very soon. When I say soon, I'm talking about days to a week, where you're going to start to see it go up like this. Not everybody tomorrow is going to be able to get a test, but pretty soon you're going to see a major escalation of capability and implementation.
The areas of the country that are not hotspots, that are not going through the terrible ordeal that New York and California and Washington State are going through, they still have a window of significant degree of being able to contain. In other words, when you test, you find somebody, you isolate them, you get them out of circulation, and you do the contact tracing. When you have a big outbreak, it's tough to do anything but mitigation. We have an opportunity now that we have the availability of testing to do that. So you're going to be hearing more about how we can inform where we're going, particularly because we have the ability to test. What we're starting to see now in the Southern Hemisphere, in Southern Africa, and in the Southern Hemisphere countries is that we're having cases that are appearing as they go into their winter season. And if, in fact, they have a substantial outbreak, it will be inevitable that we need to be prepared that we'll get a cycle around the second time. What does that mean for us and what we're doing? It totally emphasizes the need to do what we're doing in developing a vaccine, testing it quickly, and trying to get it ready so that we'll have a vaccine available for that next cycle. In addition, to do the randomized controlled trials of drugs so that we will have a menu of drugs that we have shown to be effective and shown to be safe. Because I know we'll be successful in putting this down now, but we really need to be prepared for another cycle. And what we're doing, I believe, will prepare us well.